Hello and good evening, I'm Melisa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. World Tuberculosis Day is observed on the 24th of March each year, which is very timely because the disease is back in the spotlight in Malaysia after a recent rise in reported cases. And during this Hari Raya period when many Malaysians will travel and gather with family and friends, what are the risks we should be aware of? Joining me now to help us think all of this through is Professor Dr. Ahmad Izuanuddin Ismail, who is Professor of Medicine at UiTM's Faculty of Medicine and the Acting Director of Hospital Al-Sultan Abdullah UiTM. He's also the President of the Malaysian Thoracic Society. Prof, thank you so much for joining me on the show today. So tuberculosis back in the spotlight after a recent rise in reported cases. From your perspective, Prof, how concerned should Malaysians be right now in terms of TB being a public health issue in Malaysia?
Okay. First of all, thank you, Melisa, for this kind invitation. And thank you for asking me to give my views on the current situation of the TB infection in Malaysia. But before I answer the pertinent question, let me bring back to some of the background history first. When we suffered from a COVID pandemic, our fights against TB were really badly affected. And at that time, what happened was the TB rates, TB notification rates were reduced by about 10%, and TB deaths were increased by 5%. That was back in 2020. So, I mean, it's not surprising because at that time we were focusing on fighting the COVID-19. But we have to be aware from the global point of view that put in quite a number of targets that we have to achieve. And this is stated in their target for the SDGs in 2030. And there's also this End-TB strategy 2035 set by WHO to get a target of about 90% reduction of the TB incidence rate and 95% reduction in TB mortality rate as indicator for measurements of progress by 2035. So what happened back in 2020, we come up with what we call National Strategic Plan to End TB, and that lasts between 2021 to 2030. And what we put our target was we want to get a TB notification rate to reduce to about 30 cases per 100,000 population, and also to have a TB mortality death reduced by about 50% to baseline. And we take about the number in 2015 as our baseline rate. So putting that in perspective, in 2015, the TB rate was about 79 per 100,000 population. And TB death at that time was about 1,696 deaths. And TB cases were about 24,000. Okay. Giving you some figures from 2024, okay, I know this recent spike has been talked about in the last few weeks or so. In 2024, the TB cases was about 26,183 cases. That gives your incident rates of about 76.9 per 100,000. And TB death, we still have about 2,580 deaths, and that's giving a mortality rate of 7.6 per 100,000 population. So we are way off target that we want to achieve by 2030. So that's why it is still really concerning because we're still facing with quite a number of cases every year.
Right. Yeah, thank you so much for giving us the data, because I think many people wrongly assume that TB is a disease of the past, but there's still TB happening today. It's still a disease that's a concern in terms of public health. What are the risks, Doctor, if the public awareness about TB has declined over time? How does that affect us, the public, recognizing this disease, the symptoms, and affecting early detection and diagnosis?
I think when we come up with that national strategic plan, we outline two main factor that leads to a higher number of the disease. Number one is the behavior from our population, late-seeking behavior. So, for example, for you to have to be suspected to have TB, usually the symptoms, okay, by having cough for more than 2 weeks, recurrent fever, a bit of weight loss, loss of appetite, or even having episode of coughing up blood. And what happened when someone coughing up blood? They don't think about TB. They will think about some other reason. So that will delay for them to seek treatment. So that's number one. And number two, in terms of the treatment itself, the treatment for TB takes some time. So the usual treatment is about 6 months. And to make sure that someone continue to take regular treatment, we need to have a regular follow-up and so on. So what happened most of the time, they initially take the medication because they're still having symptoms. But usually if you take the medication religiously, after about a month, the symptoms start to resolve. And then they stop taking it. But the fact that they still need to continue and taking it and complete the treatment duration. And that's how the resistance in treatments comes about and so on, because they don't complete the treatment course. And I suppose the other major factors is the fact that we had quite a number of population who suffer from chronic disease. Diabetes is still number one in Malaysia, and by having those, meaning that I mean, in country like Malaysia with very high endemicity, meaning that the TB is actually within the population. So if you suffer from all this chronic disease, meaning more than likely you will develop into an active disease sometime during your course of life.
Right. So that it's TB is closely linked to comorbidities, which unfortunately in Malaysia we have quite a high risk of a high percentage in the population of diabetes and other comorbidities. Can you talk to me a little bit about the late-seeking behaviors in terms of diagnosis? Is TB hard, easy to diagnose? I'm curious to know whether there's been improvements over the years in terms of, I guess, diagnostic tools or the speed of detection. Is there a way we can change that late-seeking behavior pattern?
Okay. Traditionally, to diagnose TB, you need to give a sputum sample. And there were two tests that we normally do. One is what we call a smear test, where we look at the sputum sample under the microscope to see if there's any TB bacteria or not in that. And number two is to have a culture where we try to see whether the TB can be grown from that or not. But nowadays, we have quite a number of advancement in terms of the diagnostic tests. Now we have the molecular diagnostic tests, such as this rapid nucleic acid amplification test, which now can detect TB as well as drug resistance within just few hours. Mm-hmm. So the advancement is there, and in fact nowadays, I mean, if you're also aware, we also have the lung health initiative, and in that lung health initiative, one of the main things that we focus on is the AI guided chest X-ray, which is really a main tool to diagnose or suspect the presence of TB or not in a patient.
Right, Prof. You mentioned drug-resistant TB. Can you talk to me more about that? How concerned are you about drug-resistant TB?
It is emerging, of course, globally and also in Malaysia. Although the number is still relatively small, but the cases is important because it's difficult to treat. And usually the cost will be much more expensive, and also it require longer treatment courses. So we need to prevent this, and the easiest part to prevent this is to make sure for someone who had what we call a normal TB to fully comply with the treatment regime, fully and making sure they complete the initial treatment regime so that it does not become a resistant TB and makes it more difficult for us to treat.
Right. You mentioned there's a national plan for this, and also international plan for this. WHO clearly has guidelines for this. But what would you say are some of the most effective measures to prevent TB transmissions, TB transmission at a population level? Do we have to adopt some of the lessons that we learned in the COVID-19 pandemic?
So we have to understand the fact that TB is a slow progressing disease, and one of the key important way to prevent it is to have an active case detection and contact tracing, um, and uh, and especially within the household and so on, and then that would be really the best preventive way to prevent this. If a contact person is diagnosed to have latent infection, for example, latent meaning that you had the TB bacteria in your body, but you're not displaying active disease. Okay, there's a preventive treatment available for that, and one can take that preventive treatment to reduce their risk, because if you diagnose with latent TB, there's about 10% increase in the lifetime for you to develop active infection.
Right. Okay, so Prof, during this Raya period, everyone's going to be traveling and gathering and meeting family, friends. What would you advise our audience today? What practical steps can we take to stop transmission, or reduce at least the risk of TB transmission?
I suppose the best advice is for all of us to stay vigilant. We have to understand that TB is really preventable, treatable, and curable, but we need to have a stronger public awareness. We need to advocate early testing if you have persistent cough, or if you have other symptoms to suggest treatment, to suggest TB infection. And if you were diagnosed with TB, you need to be fully adherent to the treatment regime, so that you don't develop a resistance in the future.
Right. Thank you so much, Prof. Professor Dr. Ahmad Izuanuddin Ismail from UiTM's Hospital Al-Sultan, Abdullah. Thank you for being on the show. We'll be right back with more on the issue of TB and public health after this. Stay tuned to Consider This. Hi, welcome back to Consider This. I'm Melisa Idris. Public health experts often say that infectious disease control is only as strong as the most vulnerable population's access to care. And this includes migrant workers, which make up a significant part of our workforce. Now, can we as a country effectively control tuberculosis if segments of the population face barriers to accessing healthcare? Joining me on the show now is Dr Tharani Loganathan, who is an associate professor with UM's Department of Social and Preventive Medicine. She's also an Atlantic Fellow for Health Equity in Southeast Asia and has written and spoken extensively on access to healthcare for migrant workers in Malaysia. Dr. Tharani, it's good to have you back on the show. Thank you so much for joining me. Let's talk about why TB is often associated with social and economic vulnerability. And I'm curious to know, for TB, which groups might you consider vulnerable populations to this disease?
Thank you for having me, Melissa. TB is called a disease of poverty, and it thrives in social and economic vulnerabilities, inequalities. The populations that are vulnerable are basically low-income populations. This is because poor living conditions, having very crowded living conditions, overcrowding, poor ventilation, also malnourished. So malnutrition is a risk factor. Because they have less resistance to infections. The lack of healthcare access. Lack of access to healthcare is a determinant because you'll be detected later. You may not be able to complete treatment. and also people who are living in high risk environments. So that is like incarcerated in prisons, detention centers, or yeah, those kind of settings. So those places, infections just spread wild. So migrant workers are at risk, but also poor people generally. Yeah.
If I just may ask you about migrant workers specifically, data from the Health Ministry shows that about 80% of the tuberculosis cases in Malaysia actually involve Malaysians, and yet I still see this perception in public discourse that it's migrant workers that are driving the spread of TB. I'm just wondering if you have any thoughts about that, why there is such a gap between the data and the public narrative.
Yeah, so stigma is a terrible thing. You have to remember in Malaysia, Melissa, the migrant workers are healthy workers. They come into the country healthy to work. To come into Malaysia, they have to go through pre-departure medical screening. And then in Malaysia, almost immediately, they have to do a medical checkup on them for MEMA. And annually, every year, they have to pass this medical checkup. So they are healthy in Malaysia. They have to be healthy to work. But of course, the conditions that they work in would put them at higher risk of infection. But it is not any different from anybody else in Malaysia.
Right. So let's talk a little bit about some of the conditions that that migrant workers face, the barriers that they face when accessing healthcare. For TB, what barriers for TB detection and treatment? What makes it more difficult for migrant workers to access those services?
Okay, specifically for TB. So I just mentioned the mandatory annual examination they have to do for MEMA. So basically, if they are suspected of TB infection, not even confirmed, suspected with maybe some changes on chest X-ray, it might or might not be TB. They fail their medical examination and will be deported, have to go back. No work permit and would have to go back. So this is a major stigma. So every migrant worker would know if they come forward and they are diagnosed or suspected of TB, that they cannot work in Malaysia. So even if they are symptomatic, they would be reluctant, very reluctant to be diagnosed with TB. So this is a major barrier.
Right. So that's the kind of immigration consequences that may affect, I guess, willingness to step up and seek treatment or diagnosis. Talk to me about the cost involved, because how much of a deterrent is cost? Because non-citizens actually face higher healthcare fees, don't they?
Yeah, you're very right. But TB is one of those infectious diseases in Malaysia that is actually free at MOH government clinics. But just to put to introduce this to you, TB medication is free, okay, but the investigations that go into diagnosing the TB is not. So if you are not diagnosed with TB yet and you have to go through chest x-rays, sputum tests, blood tests, whatever, to establish that diagnosis, you will be charged for those. So that could be prohibitive. The same thing happened during COVID-19. Yeah. So the investigations are not free, especially if you do not have a diagnosis.
Thank you for bringing up COVID-19. What did we learn? What lessons did we learn from that, particularly in the diagnosis? When you are making the comparison to COVID, I assume that the tests for COVID was the cost for that was borne by the migrant worker themselves?
Yeah, I mean, especially in the initial days when we were asking people to come forward to be screened, so come to the clinic and get screened. So migrant workers would come and then they would realize that they have to pay for it. It was not free. It was different when MOH would come to your neighborhood and ask you to, I mean, they that means they are requesting the test, they suspect you of the disease, and that would be free. But if you're walking in, you might be symptomatic, but if you're walking in, you have to pay for it. So this is a loophole there. So I think Melissa, that there is a difference between COVID-19 and TB. I mean, they are both infectious diseases. They both spread by respiratory diseases, but they're quite different. So COVID-19, it's an acute infection, and so on. TB is something that doesn't spread so easily.
Right. You mentioned a little bit about the, I guess, the job consequences of when migrant workers come out to seek treatment, to seek diagnosis. I do wonder what role employers play in this, in facilitating or even in discouraging workers from seeking medical care, medical treatment.
So, Melissa, this is a bit of a difficult question here because, you can imagine it's a similar quandary that you put the employers in, because they, of course, they want their workforce to be healthy, so work continues. But if you have a TB diagnosis in your factory or in your employ, basically there will be disruption, because MOH, TB is a preventable disease, and it's a notifiable disease under the Prevention and Control of Infectious Disease Act 342. So basically, the public health authorities would have to come in. They have to screen everybody. They have to make sure no one has TB. So it's like similar to COVID. Yeah. So it's those things. So work disruption is a problem.
Right. Because of I guess, the public health element of this, I do wonder what you would like, given your extensive background in this, Dr. Tharani, is there anything you would like to see improved in the way Malaysia approaches migrant health and infectious disease control? And I'm speaking more broadly here, beyond even TB.
Yeah. So I would say, first of all, about TB and infectious disease, we need to separate it from immigration. It is a public health issue. It is a health issue. It needs to be treated, and if you do not detect and treat properly, so TB, basically you need to treat for 6 months. So, and a treatment disruption, discontinuation would cause other problems that's not good for public health either, because we get things called multi-drug resistant TB, which is really hard to handle. Okay, so that's the reason why public health, the doctors involved are very concerned about TB. So 6 months of treatment. So I would say, we do not want immigration action. We want everyone who is diagnosed with TB to be initiated on TB treatment. So you can't be saying that this is a foreigner, so they need to be sent home, because deportation does not happen overnight. They will still be in our detention camps or wherever, and that place would also get TB. So treatment has to be completed, has to be initiated and completed. I would say it's better if they stay in Malaysia and they get treated properly. If they do send them off back to their country, they need to make sure that the treatment process is not interrupted, so there's continuity of care. This is just humanitarian. So it's just like, I am referring a case back to Indonesia. I have to call back the doctor in Indonesia and make sure they have the medical history and they know that this is a patient that needs. So the treatment is not disrupted. This is medical practice and humanitarian care. We cannot, TB is not good for any country. Yeah.
Anything beyond TB, doctor?
Yeah, so beyond TB as well, healthcare and immigration does not mix very well. We've got many examples of this. Regarding healthcare costs, so we have Melisa, you rightly pointed out that the cost for the treatment is very expensive in klinik kesihatan, and migrant workers have insurance which does not cover outpatient care. It only covers inpatient care, so hospitalization. So this is a prohibitive thing. So they may not come in unless it's really necessary, and that could have consequences to all of us, to their health and to all of us as well. So well, if we are not going to revise the fees, we should make sure insurance covers everything, right? Yeah.
Yeah. Dr. Tharani, thank you so much for being on the show with me today. Dr. Tharani Loganathan from UM's Department of Social and Preventive Medicine. And wrapping up this episode of Consider This, I'm Melisa Idris signing off for the evening. Thank you so much for watching and good night.